Many of us thought that after the human genome was sequenced, we would have all the answers, and we don't. And here to talk about that is my colleague and fellow dean, Seng Chia. Seng is the dean of the School of Public Health at National University of Singapore, the Saw Swee Hock School of Public Health, and welcome him to the podium.
Mr. Gan Kim Yong, Minister for Health, Singapore, Professor Detlef Ganton, Founding President, AMID Alliance, Professor Michael Clegg, Co-President, World Health Summit, distinguished guests, ladies and gentlemen. In 1948, the late Sir Richard Doll examined the personal histories of a large number of lung cancer patients and compared them to subjects without lung cancer. He was surprised by his findings. The principal difference they found was that there were more smokers among cancer patients. This was totally unexpected because smoking was considered harmless. Everyone was smoking. Doll himself was smoking. Smoking was advertised as good for health. Doctors smoked. They even appeared on cigarette advertisements. The Secretary of the Medical Research Council told Doll and Hill, "You'll be a sensation when you publish your findings." Sadly, he was wrong. The findings were ignored. The Department of Health Advisory Committee on Cancer argued that the statistical association between smoking and lung cancer did not prove causation, and to tell people smoking might be dangerous would only cause unnecessary panic. Undaunted, Doll started the British Doctor Study. He recruited 34,000 healthy male doctors, followed them up for occurrence of various diseases, and 5 years later, it was evident that cigarette smoking was associated not only with lung cancer, but also heart attacks. In spite of this overwhelming evidence, public policy interventions to control smoking were not forthcoming. The consumption of cigarettes continued to rise. It took nearly 3 decades before the consumption of cigarettes in the US returned to the pre-1950 levels. This smoking and lung cancer story illustrates the kind of gap that has become part of public health landscape, the huge gap between research findings and its translation into public health programs and policies. Can we do better in this post-genomic era? Today, we can interrogate our entire genome using dense DNA chips and sequencing methods. We now have the tools to collect, process, and store incredible volumes of digital data. We no longer talk about megabytes. The new buzzwords are exabytes and zettabytes. We are technologically empowered, but we are also discovering that the world around us is highly complex, not only in the traditional domain of physical and biological world, but also in behavioral, organizational, and societal domains. We embarked on the Human Genome Project in the 1990s with high expectations. The hope was that when we have completed sequencing the human genome, it will revolutionize our ability to diagnose, treat, and prevent the signature diseases of our time. The naive premise was that there must be decisive genetic determinants of these diseases, and finding them would enable us to turn the tide on the rising epidemic of these non-communicable diseases. But now, after a decade since the completion of the Human Genome Project and a multitude of genome-wide association studies, the disappointing conclusion is that they have not explained as much of the genetic component of many diseases. And the genetic determinants we have found are by no means simple or decisive. Many of the genetic markers that have been found are in what have been labeled junk DNA. Just last month, the Encyclopedia of DNA Elements Consortium simultaneously published 30 papers highlighting that within junk DNA are embedded complex networks of switches and circuits that interact with non-genomic environmental factors. There's therefore an immense complexity in disease causation at the biological level. There's also a great deal of complexity at the behavioral level. The challenge of understanding and influencing individual behavior has long been a bugbear of health promotion. We are continually unearthing novel influences on decisions which bear on health behaviors, and the direction of those influences is not always rational. Take, for example, smoking cessation. We are aware that genetic variants such as CYP2D6 and GSTM1 confer increased health risks from smoking, but the effects are so small that they should not influence the behavior of smokers. As expected, giving smokers feedback on their increased risk from single genes does not alter quitting habits. But feedback on the same small increased risk based on multiple genes significantly increase quitting rates. There are no known prevention strategies for Alzheimer's disease. However, family members who are told that they carry the higher risk ApoE gene will adopt a healthier diet, a healthier lifestyle, believing that it will somehow reduce their risk. For breast cancer, we know that hormone replacement therapy increases the risk of developing postmenopausal breast cancer by 30%. But having the first full-term pregnancy after age 40 doubles the risk of breast cancer. And yet, in modern-day Singapore, it is probably easier to convince a woman to lower her breast cancer risk by 1/3 through forfeiting hormone replacement therapy than to convince her to lower her breast cancer risk by half through starting the families early. Apart from biological and behavioral complexities, a third layer of complexity is that of our healthcare systems. The healthcare delivery ecosystem is populated by multiple nested, overlapping, and interconnected elements. Complexity, fragmentation, and specialization characterize every level, from policy to organization to services. Traditionally, this complexity is represented in linear models. This prevailing model of thinking is a bias imported from other fields of science, a bias towards reductionism, determinism, and simple explanations. This posture has served us well, from Newtonian mechanics to macroeconomics. The search is for a parsimonious set of linear cause-effect axioms that allow us to understand, explain, and predict the entire system. But there's a countervailing approach, one that has been slowly gathering momentum in the fields of physics, computer science, and ecology, an approach that is still at the margins of public health. This approach is complexity science. Complexity science views aggregate systems not like machines, but like living organisms. Complex and adaptive subsystems that interact through networks in dynamic and non-linear fashion. I submit that the time has come for public health practice, research, and education to embrace complexity and the approach of complexity science. Only then will we be in a position to address the triple burden of the epidemic of NCDs, the threat of ID pandemics, and the sustainability and efficiency of our healthcare system. When we survey the history of public health in the developed world, 3 eras come into view. Public Health 1.0 is the era where the dominant health challenges were addressed through society-wide environmental and economic developments. Dramatic improvement of the health of populations were realized through clean water supply, environmental sanitation, proper nutrition, and housing. Public Health 2.0 is the era where interventions were directed at single primary risk factors: vaccination against infectious diseases, control of selected risk factors such as tobacco, smoking. Public Health 3.0, our present post-genomic era, is when the challenges confronting us are no longer responsive to single decisive interventions, but require a proactive approach that embraces complexity. If I may be so bold, let me propose 3 strategies to move Public Health 3.0 forward. Firstly, Public Health 3.0 should focus on translation of discoveries about multifactorial causes of diseases into programs and policies. Academic public health research has traditionally focused on etiological research, eliciting the determinants of diseases. This mode of work may be interesting, but if meaningful real-world translation is the end goal, then it is grossly inadequate. A related issue is the academic propensity to endlessly repeat etiologic studies in various population subgroups. The effects of major etiological factors are generally similar across populations. What is needed is the investigation of associated factors that are plausible, non-universal, and highly contextual. This is the first strategy for Public Health 3.0, to focus not on single etiological factors, but on the translation of discoveries about multifactorial causes of diseases into programs and policies. The second strategy for Public Health 3.0 is to embrace the role of behavioral and implementation science, including behavioral economics. Much of the key determinants of successful translation lie within the sphere of behavior. Yet public health research remains highly medicalized, reluctant to leave the secure footing of biomedical research for the uncertainties of the behavioral sciences. There's no other way. The road to implementation of programs and policy aimed at lifestyle change necessarily runs through the terrain of behavioral sciences. 2 recent articles in Science drew attention to this. Targeting automatic behavior is much more effective than rational, cognitive, reflective behavior. New social norms regarding healthier behaviors and practices can be achieved through taking a macroeconomic perspective and tackling multiple non-medical domains. Let me illustrate how this strategy of embracing behavioral and implementation science has influenced a project that our school has undertaken, the Total Workplace Safety and Health Initiative. In Singapore, as in many other countries, workplace health protection have traditionally been divorced from workplace health promotion programs. This separation occurs at multiple levels: governmental, management, and workers. Protection is mandated by legislation, whereas health promotion is usually through advisories. Naturally, workers and management have greater incentive to focus on protocols for protection rather than programs that protect their health. However, the rising prevalence of chronic diseases among younger individuals, as well as the extension of retirement age, means employers will increasingly be saddled with workers suffering from chronic diseases. This has implications on the cost of doing business. Our school, in partnership with the Ministry of Manpower, Ministry of Health, employer and employee organization, as well as the School of Business, are conducting pilot studies to develop a total workplace safety and health system aimed at integrating health protection and health promotion through a management system, as well as training and enabling service providers. We develop the conceptual framework, create assessment tool, conduct surveys, pilot interventions, and project the impact at a national level. If accepted for implementation, this project becomes a test bed for research into implementation science and behavioral economics. A third strategy of Public Health 3.0 should be to making use of complex simulation and modeling to integrate existing and new data to project the impact of public health programs and policies. It is common practice to make projections and possible scenarios to aid decision-making. However, many of these draw on retrospective data, as relevant current data is often difficult to come by, and future projections lack the necessary granularity. Consider the analogy of driving a car. The driver decides how to steer the car based on three sources of information: the rear view mirror, representing historical information; the dashboard, the current information; and his view of the road ahead, future projection. Public health decision makers frequently have to make do without a dashboard of current data or reliable future projections. We are currently developing a population health metrics and analytics platform consisting of three major components: a modeling and simulation core, an aggregate data repository, and a cohort of 50,000 Singaporeans where we continuously monitor their health, their behavior, and their preferences. Our first task was the projection of the burden of type 2 diabetes in Singapore in the year 2050. Most existing projections have been created based on historical prevalence of diabetes by age, gender, and ethnic groups. Our new projection has taken into account rising obesity trends as well as genetic profiles of Singapore population. In 2010, the prevalence of diabetes of those aged 18 to 69 was 11.3%. Based on aging of the population alone, the prevalence of diabetes in 2050 will increase to about 13%. However, if we incorporate the genetic profile and the recent rising obesity trend, the prevalence will be 15%. The black central core in our population pyramid represents the proportion of diabetics among Singapore residents. By 2050, our population pyramid will look more like an apple, given the current low fertility rate. The black central core will have increased dramatically. By 2050, there will be 1 million diabetics in Singapore, with a substantial proportion above age of 70. This ability to project the future burden of diseases, taking into account multiple factors, is a starting point that helps us to synthesize our understanding of complexity into an intuitive and concrete form that enables evaluation of the potential impact of public health interventions. Finally, Public Health 3.0 needs to be an era where we focus on primary prevention. The current epidemic of diabetes is fueled by aging population and the rising prevalence of obesity among the young and middle-aged. We do need to expand the capacity of our healthcare system. We do need to diagnose our diabetics early and care for them in more cost-effective and innovative ways. The existing healthcare system is like a water basin filled with diabetics threatening to flood the system. We need to change that basin into a bathtub so that we can prevent the costly complications of poorly managed diabetes. That's secondary and tertiary prevention taking place primarily within the healthcare sector, be it primary, secondary, or tertiary healthcare institutions. However, at the same time, we need to slow the tap. That's primary prevention, which occur almost exclusively outside the healthcare sector. I hope I've given you a glimpse of Public Health 3.0. We need to embrace the increasing complexity, integrate with multiple disciplines for new systems and tools, and move upstream with a recommitment into primary prevention. Together, we can confront these complexities, these complex public health issues of the post-genomic era. And together, we can turn discovery into healthier communities. Thank you.